So we left off last week talking a little bit about how your period starts in your brain. And I'll just remind you again, I'm picking up exactly where I left off from last week's episode. So if this is not making any sense to you, go back and listen to last week's so that you can get the context for this week. So your period starts in your brain, essentially, right? It starts in the hypothalamus, where we release follicular stimulating hormone and luteinizing hormone. And this is particularly important for our women with PCOS, because we can clinically see a very high ratio of luteinizing hormone to follicular stimulating hormone. So normally, if you want to understand, if you suspect that you might have PCOS, let's say, it would behoove you, let's say, and your functional medicine practitioner or your allopathic physician, whoever you're working with, to test those ratios. So the best time to test LH and FSH, where we want to get that 1-to-1 ratio, which what would be considered normal, is day 2 or 3 of your menstrual cycle. So day 2 or 3 of your bleed week is where we want to be measuring. So women with polycystic ovary syndrome, we can have marked, we'll say, luteinizing hormone elevation levels in this time period, where we can see levels rising 2 to 3 times that of follicular stimulating hormones. This is a really good time to catch it. And there are many reasons. One of the reasons is usually that insulin levels in the body are too high. So if your insulin levels if you have this sort of state of hyperinsulinemia, this can elevate luteinizing hormone. Another reason, which we won't necessarily go into now, is hyperprolactinemia, meaning that the levels of prolactin are too high as well. They're also causing a surge in luteinizing hormone. And if you know anything about the menstrual cycle, we know that the luteinizing hormone is very, very important right before ovulation. It is what actually gets the follicle to release the primary follicle that is developed under estrogen's influence, or more accurately, estradiol's influence. We have this elevated level of estradiol for somewhere between 40 to 50 hours, starting at about day 10 of your cycle. And then following that, we have about a 10-hour elevation, this major surge in luteinizing hormone. So if you are already at a 2 to 3 times, elevated above baseline level of luteinizing hormone, you're not going to get much of a surge, right? And it's the surge, it's the differential between baseline and the apex of that curve that is going to cause the follicle to release that egg. Now, with polycystic ovary syndrome, and this is, obviously like a podcast and a book, several books unto itself, we see a lot of other contributing factors to PCOS. One of them, and I teach this in my Estima certification program to my practitioners and health coaches, is that we see genetically, there does seem to be some genetic component to PCOS, in that we see, in particular, we see the gene that converts testosterone to dihydrotestosterone, which is, a layman's term might be like super testosterone, right? Like DHT, or dihydrotestosterone, is about 6 to 7 times more potent than your regular run-of-the-mill testosterone. And we see with women with PCOS that there is, this like almost 1,000-fold increase, in some cases, thousands of folds of increase in activity of this 5-alpha reductase activity. So the gene itself, for those of you that want to know, is SRD5A2. And we see that upregulation in the ovarian follicle in women with PCOS. And then, of course, the metabolites of SRD5A2 also, little rascals, act as inhibitors of aromatase, which is the CYP19A1 gene, which is basically the gene that's involved in the testosterone to estrogen conversion. And of course, those two things, you're getting testosterone converted into dihydrotestosterone, that super testosterone, and an inhibition of estrogen production from testosterone. So estrogen is created from testosterone. We have these two pathogenicities, let's say, that contribute to the clinical picture, and of course the physiological abnormalities of PCOS. So when we think about a woman who has, or put, if you're a woman, let's say, where you have, some of the classic textbook signs of PCOS are going to be thinning hair at the temples. Okay. So that's one thing. We'll often see some thickening, we'll say, or like very thick, wiry hairs at the chin and kind of along the hormonal area of the face, which is like the lower half of the face. You may also see like chest hair, back hair on a woman where we wouldn't normally see it. In that way, because we have this like testosteronization, let's say, of this woman, where there's an excess amount of testosterone, rather, her body will start to behave more male. And so we will see this sort of male pattern baldness, more hair on the face, chest, and back. You might also even see like ectopic fat distribution, meaning that she's going to start putting on adipose tissue or fat in a manner consistent with the way that a male might put on excess adipose tissue as well, which is kind of through the central region, like through the belly. We often call it like the spare tire, let's say. I hate that word, but just for kind of a visual, like sort of like a thickening through the midline. From a, body morphology, like kind of perspective, she's more of an apple than she is a pear. Okay. So someone who is a bit hip heavy, like that's me, right? I got hips and a booty and I have some to spare. You might call my body type more of a pear, right? Kind of like heavier on the bottom, let's say. This is like, I'm making sweeping generalizations right now, but just as a visual. Okay. So someone who has PCOS and who's had it for a long time and it's gone underdiagnosed or untreated or whatever, we may see that excess adiposity through like that centralized deposition of fat, giving her a less of a waist and more of that apple type of presentation. Okay. So, we're going to talk a little bit, we've talked a lot about, insulin reduction, and insulin resistance. I talked a lot about that in the last podcast. But moving on into, kind of some of the frustrations that a woman with PCOS, might have. Like one, obviously, is that having this pathogenicity, right? Having this kind of, presentation of like excess testosterones and like the dihydrotestosterones, inhibition of aromatase activity. The net here is that the ovarian follicles fail to reach ovulation. Okay. It causes a delay in ovulation, right? Which then, will cause irregular periods, absent periods, non-existent periods. I think I mentioned this last time that this is 100 million women worldwide. This is not a number to be ignored. Okay. This is the most common endocrine disrupting, this endocrine disorder of women, in reproductive age. And it is the leading cause, the number one cause of ovulatory infertility. Okay. Now I won't get into, I will get into it a little bit. I have a problem with many words. As a word nerd, the name PCOS, squeak of a misnomer. Not all women have cysts on their ovaries. Okay. So about 20% of women who do not qualify for the diagnosis of PCOS actually have these so-called cysts, right? And 30% of women who have PCOS do not exhibit these cysts. And even more accurately, these are not really cysts. Like this is like, it's not like a pustule, let's say, or like like an acne breakout. These are actually follicles that have not gone through the maturation process. Of course, the biggest frustration for a woman with PCOS obviously is her fertility. This becomes particularly important for her if she decides that she wants to have children. Obviously, I remember for myself, like, I was like, don't want them, don't want them, don't want them, don't want them. Oh my God, I really want kids. It was like a light switch all of a sudden. I couldn't stop staring at babies in parks and noticing children everywhere. And it was just like basically my biology telling me that, yeah, like you're ready now. Like it's time. And for a woman who, I was lucky enough to be, pregnant in my second month of trying. But the first month when I got my period, I was devastated. Okay. So I cannot imagine And I won't pretend to imagine what it's like to go 4 months, 6 months, 9 months, 1 year without success. That is a very long time for someone who wants to be pregnant. That is by far the biggest challenge is their fertility. And even if you don't care about having children, if that is not in the cards for you, as a woman, it is one of your vital signs, one of blood pressure and oxygen saturation and heart rate and respiratory rate. So is the optimal cycling and optimization in general, broadly, of your menstrual cycle. So as it relates to intermittent fasting, which is what this lecture series is all about, fasting is very well tolerated for my women with PCOS. And in fact, it's actually one of my most favorite tools to use with my ladies who I am suspecting or I have confirmed that they have some degree of polycystic ovary syndrome. So how does that look? Well, last week I was talking a little bit about some of the different types of fasts. So the non-caloric liquid fast and the caloric liquid fast and calorie restriction. There's a lot of different ways to, what's the saying? A lot of different ways to skin a cat, I think. It's such a different and very disturbing visual, but there's a lot of different ways to do it. I personally, depending on the severity of the case and depending on, is she trying to get pregnant, we will, and if we can kind of figure out at where she is generally in her cycle, I am going to very quickly try and build up a fasting tolerance in this woman, meaning that we are going to be doing a minimum of 12 hours of fasting every single day. But the idea is to ramp that up as quickly as we can. So as quickly as I can, I'm going to try to get her on a 16-8, so a 16-hour fast, an 8-hour eating window, and ideally with a night limiter, meaning that she is going to eat, let's say within 8 hours, but she's going to finish eating 2 to 3 hours before her bedtime. So that means that she might start eating earlier in the day, which is a little bit opposite to what I find currently, kind of exists in the fasting culture. A lot of people who practice intermittent fasting, if they're doing like a 16-8, let's say, they try to delay their eating until, if it's a 16-8, it might be they'll delay their eating until noon, and then they'll eat if over that course of that 8 hours, like 12 to 8 p.m., and then go to sleep. I find 8 p.m. Just a squeak late to be having your last meal, because 2-hour clearance is 10 o'clock in the evening, 3-hour clearance, which is better, is 11. And that's right around the time when most of us at least should be going to bed. I mean, I'm kind of a 9 p.m. kind of girl these days. I love going to bed at about 9:30. It's like, whew, what a day. I'm in my, doing my oils in the evening and my creams and all the stuff. So for a woman with PCOS, as quickly, and again, this is all dependent on the individual, right? But as quickly as I can get her up to a 16-8. And if it's a very severe case, I'm going to get her to be doing like 24-hour fast, 36 and 48-hour fasts as quickly and as often as she can tolerate that. So that might be once a week. If we're talking about a morbidly obese patient, someone who also has a lot of weight to lose, we might do that several times a week as well. Okay, so kind of just summarizing this. So if you're watching this on YouTube, you're going to see this really great illustration here where we're looking at sort of the clinical picture of PCOS is a hallmark. There's some hallmark features here: insulin resistance, which we talked about last week, dyslipidemia, where we have an elevation of lipids, which are not ideal. We may have a diet that's not necessarily well suited for her. And that all leads to this kind of systemic inflammation, which is going to lead to sort of poor oocyte quality, impaired ovulation, or absent ovulation altogether. So fasting, kind of as a summary, like where fasting fits in here, it is like, the Beyonce and Jay-Z, kind of perfect pairing. Like, individually they make really great music, and then together it's like, Crazy in Love and all the, the great music that they make. Fasting and PCOS is like a match made in heaven. It's like peanut butter and jelly, it's like they are very, very well suited. And often when we start to get a woman who has PCOS more metabolically healthy, one of the things that I do is actually start paring back the fasting, right? And you'll hear me say this over and again, probably until you're tired of me saying it, but we need to hear things many times, sometimes for them to kind of sink in. But the diet that you follow when you're unhealthy is not going to be the same diet that you do when you're healthy. Okay. So you may need to fast aggressively. Let's say if you have PCOS and you don't have a regular period, we might need to improve that FSH to LH ratio by fasting day 1, day 2, day 3, day 4 of your cycle, let's say. We may need to get you to start lifting weights so that you are a better glucose disposal agent, negating the need for those sort of high insulin outputs. And then, there are other things, of course, that we can add into that, like stress management and, all of that. But like fasting, we'll kind of keep it to fasting, and I'll throw in a little bit of exercise as well too, are very, very important for correcting this problem. Now, I will say one of the questions, interestingly, that I get, which I really think is a good question, it means you're paying attention. Sometimes I'll say something like lifting weights is one of the best things that you can do for PCOS because it makes you a better, as you grow your functional tissue, as you grow your, lean muscle mass, you are going to better control your insulin output. And the question that I get, and I've had this enough times that it's worth bringing up, is, well, isn't weightlifting going to make her testosterone worse? Because when she's lifting weights, we know that, as we build more tissue, we naturally will increase her testosterone. And the answer is that the effects that you are going to have, the adaptations that you have when you are resistance training specifically, and of course there can be cardio in there as well. And usually it's warranted with a woman with PCOS to be developing a program with a base of resistance training as well as cardiovascular work. But the amount of healthy adaptation that you're going to have. So the improvement in lipid control, the improvement in systemic inflammation. So the reduction in cytokines, the reduction in C-reactive protein. You'll see this like the TNF, like the tumor necrosis factor alpha, some of the reduction in prostaglandins. All of these things are going to be improved. So it is the net adaptation to resistance training is better for a woman with PCOS. And then, of course, not to mention that her ability to dispose of circulating glucose is going to be augmented when she has more muscle, which is, I've mentioned, is going to negate the load on the beta cells of the pancreas to continually be outputting insulin. So we don't have this like hyperinsulinemic state. I was talking last week about insulin resistance, and one of the first places, of course, that we see insulin resistance is, shocker, it's in the muscle. And it's not so much that that we can't actually get, it's not that we can't, what's happening is the cell is essentially starving. Like we can't actually pull we can't get the glucose into glycogen. So when we are resistance training, that improves insulin resistance almost from at the level of the myocyte almost immediately. So resistance training for a woman with PCOS, also very, very important.